Thank you very much. I want to thank Peter for inviting me and Dr. Yang as well. I've really enjoyed my visit. It's my first time to Ann Arbor, and I'm very pleased that you arranged warm weather for me because I've been warned. I think I put this visit off for a year, but it landed in February. So thanks for coming early in the morning, and I have a few things to talk about with you. And I've entitled this talk, Inflammatory Bowel Disease, Treatment Strategies and a Way Forward, sufficiently vague that it could be about just about anything that I wanted to talk about. Here are my disclosures, just so you can assess my statements for veracity, compare them against who I've worked with. Suffice it to say that none of us in this field actually invent the drugs. We just try to figure out how to use them. So it's essential that we continue to work with pharmaceutical companies if we're to advance this field. Here are the learning objectives. By the end, I would hope that you might understand how anti-TNF agents have really shaped what we expect of therapeutic outcomes in the treatment of IBD and how it's influenced our thinking about the strategy of treatment. In addition, I'll present information about limitations in our current knowledge base, about risks and benefits of these different strategies. And then I'll present, as Peter said, a little bit about the logic in support of large epidemiologic studies that will further advance our knowledge in these areas, and particularly about disease prognostication, as well as environmental risk factors for IBD. Now, when I was a GI fellow in 1990, this was the armamentarium that we had to treat inflammatory bowel disease. Really, it looked much the same for Crohn's disease and ulcerative colitis. Of course, 5-aminosalicylates had been around for many decades in the form of sulfasalazine, in newer forms with different release mechanisms, starting in the early 1990s, late 1980s. Antibiotics have been used despite a fairly slim base of evidence for Crohn's disease and largely not used for ulcerative colitis. Corticosteroids, of course, had changed mortality rates, particularly in ulcerative colitis, when they began to be used more than 5 decades ago. But have other problems that we're all aware of. And then it wasn't until the late 80s that we began to use immune modulators as treatments for patients with refractory Crohn's disease, and increasingly in ulcerative colitis as well, although the database there has been relatively thin as well. And then second-line agents have been methotrexate for the treatment of Crohn's disease and cyclosporin for ulcerative colitis when it's really refractory, steroid refractory, hospitalized patients. So that's all we had. And suffice it to say that these were adequate for most patients, but for many patients, you would see them run through one treatment and another. Particularly in tertiary care settings, we would see these refractory patients who had horrendous outcomes. And in fact, we still do see this. Well, a revolution occurred just as I was coming out of my fellowship and started to do clinical research, and I was very fortunate to be around at the time when this revolution was beginning. And it started with the recognition by Dutch investigator Sander van Deventer that granulomas require tumor necrosis factor alpha to form. And he reasoned that since Crohn's disease is a granulomatous disease, at least in some patients, that perhaps blocking TNF would be therapeutically beneficial in patients with Crohn's disease. There was an agent that had been used in sepsis trials, which was an anti-TNF antibody. That was created by Centocor, or actually produced by Centocor, not created. And he used this agent in a girl with ulcerative colitis and had apparent therapeutic benefit. Then he extended these observations to 10 more patients and showed that 8 out of 10 had a phenomenal response in Crohn's disease. And this led to randomized controlled trials, the first of which I was lucky enough to be involved in. And have carried forward with that. And you know the subsequent history, of course. There have been many randomized controlled trials, and I'll quickly summarize the data about anti-TNFs and Crohn's disease and ulcerative colitis. And you'll realize that all of these are based on a template of a murine antibody. The fusion proteins, etanercept and onercept, although etanercept is approved in rheumatoid arthritis, there have been 2 negative studies in Crohn's disease. Now, it's unclear if this particular agent doesn't work in Crohn's because of lack of dose ranging study, which is the case. They didn't go through a wide range of doses. They simply applied the dose used in rheumatoid arthritis. Or is it mechanistically different? But the ones that clearly have shown evidence of efficacy in Crohn's disease, and at least for infliximab and ulcerative colitis, are these agents, which are chimeric anti-TNF antibody, infliximab, which we've had for 10 years now, adalimumab, which is said to be a human anti-TNF antibody, and this pegylated FAB fragment, which is humanized, which formerly had been called CDP-870, now known as certolizumab pegol, and that's 95% human composition. Now, I want to point out that although these are said to be to a greater or lesser degree human or humanized, none of us in our natural healthy states have anti-TNF antibodies. So these are all artificial constructs, and all of them, to a greater or lesser degree, have the possibility of developing immunogenicity and antibodies against the drug, which could then lead to infusion reactions, injection site reactions, and probably more importantly, loss of response over time. Now, I also want to point out that historically, the benchmark for measuring outcomes in Crohn's disease studies, and most of my comments in this talk will focus on Crohn's disease, where a lot more is known. The standard benchmark has been the Crohn's Disease Activity Index. This arose out of the recognition that Crohn's disease is a very, very heterogeneous condition. Patients may have purely abdominal pain as their manifestation, may have diarrhea, they may have extraintestinal manifestations, or any combination of these things. And so in the development of the cooperative Crohn's disease studies in the United States in the late 1970s, this was created and validated as a composite index of disease activity. Now, you should realize that when you look at this list of items, some of them are highly subjective on the part of the patient, some of them are observations on the part of the physician, some of them are physiologic measures such as hematocrit or body weight down here. And so this is not a reflection of biologic inflammation. It is somewhere in between a self-reported outcome of a patient and a biological index. And if, in fact, you try to correlate the Crohn's disease activity with inflammatory markers or endoscopic appearance, there's not a very strong correlation. And there's a moderate correlation with purely patient-reported outcomes. But this has been the standard yardstick for studies. And I want to summarize the kinds of studies that we've seen. There have certainly been short-term induction studies, the first one by Steph Targan, and we were involved in that study as well. And that was looking at infliximab as an induction therapy, short-term. Classic one looked at adalimumab. These were placebo-controlled studies with very relatively short-term endpoints at 4 weeks or 12 weeks. They were using the standard for response definition of a drop from baseline of 70 or 100 points in the CDAI, and also typically looking at remission, which is an absolute CDAI of less than 150 at the primary endpoint. And then you have longer-term maintenance studies. And by and large, these have been induction by open-label treatment followed by maintenance of response in the initial responders, using the same outcome definitions over time. Typically, these would go on for 6 to 12 months. And that's what we mean by maintenance. And then there's one study which was somewhat different, kind of an outlier study called PRECISE-1, which was looking at certolizumab pegol. And this was double-blinded placebo-controlled induction and double-blinded placebo-controlled maintenance, not selecting for the responders, so it didn't have this enrichment for the initial responders, using a 100-point reduction in CDAI as their response definition, and also co-primary endpoints at week 6 and 26. So this was categorically a different study and had a different look at the outcomes.